patients initiate on ibrutinib in the frontline or relapse setting, patients are started at the full dose of the drug, and monitoring is usually by in-clinic visits that include a physical exam as well as routine blood work. The purpose of this monitoring is both to ensure that the patient is responding to treatment, but also that they are tolerating the therapy. Though many patients with bulky lymph nodes or other disease may be started on allopurinol or other medications to mitigate any cell turnover and rise in the uric acid, tumor lysis monitoring otherwise is not standardly employed, or certainly not frequently, for patients receiving ibrutinib. In terms of response, patients can have response often within the week in terms of improvement in symptoms or their lymph nodes, and their subsequent follow-up again will consist of exam as well as testing to make sure that they're responding and tolerating the medication. If patients are doing well, often these visits are spaced out to every several weeks and moving forward, adjusted if the patient develops any side effects or toxicities. The response for patients outside of a clinical trial, as mentioned, should include the physical exam as well as blood work. CT scans and imaging are not necessarily required unless there's bulky disease that needs to be monitored that way, and there's lack of evidence of response in other regions. Development of resistance to ibrutinib, especially in the frontline setting, is not common and would be incredibly rare, especially in the first year on the drug. Therefore, if a patient has evidence of any kind of progressive disease early on the therapy, one should look for other causes such as transformation of the CLL. In terms of response, this is looking for reduction in whatever symptoms or disease was the reason for patients to start on therapy. Complete responses to ibrutinib often take time, usually in the period of years. One study suggested that after 5 years of frontline follow-up, that complete response rates increased to almost 30%, but these responses took time. Minimal residual disease, or MRD negativity, has historically been an important milestone to predict length of remission for patients receiving chemoimmunotherapy, and more studies are also showing MRD importance in predicting longitudinal responses and PFS for venetoclax. However, because MRD achievement is an uncommon event for patients receiving ibrutinib monotherapy and doesn't necessarily mean that patients can't still have very long responses on the drug, MRD testing is not employed outside of clinical trials for ibrutinib, certainly not as monotherapy. In terms of patients and their risk of relapse, as mentioned for ibrutinib monotherapy as used in this case, one would not use MRD monitoring in clinical practice. In clinical trials, when the drug is used in combination with other targeted agents or anti-CD20 antibodies, one might use MRD testing, but again, within the context of clinical trials.